I started out as a reporter at the FT, then I worked at the Times, and I worked at the BBC. And my first editor said to me that one of the great sins in journalism is throat clearing. So you know that thing where you read a story and there are kind of 4 paragraphs that tell you what the story might tell you but doesn't tell you anything? That's like a terrible sin. And I'm just going to show you how awful it is, because I'm going to do, if you don't mind, a couple of minutes of throat clearing so that you understand what we're trying to do here. As I said, I worked in different newsrooms. When I started out at the FT, we probably produced about 200 stories a day in the paper. By the time I was at the Times, because of the internet and everything, we were probably doing about 400 stories a day. By the time I left the BBC, we were doing about 4 seconds of news for every second of the day. And that's a newsroom of about 8,000 people, and I was sitting there thinking, I'm finding it harder and harder to understand what's really going on, how things actually happen. And I thought, could you build a slow newsroom, hence the name Tortoise, Slow News? And when you were thinking about that, when we started thinking then about what you could do with time, one of the questions would be, well, what's the benefit of that? How would that work? And our thinking was that if you took a little more time, you might come to a better understanding, and that better understanding is the first step to mending things. And so our journalism has always probably strayed up to the line of activism and sort of teetered over the edge, and I hope we're going to do a little teetering today. The reason why we're here is that Jess Burley, who you know and is one of the world's great humans, got in touch with me, and our think-ins, our approach to journalism was really born of a moment at Great Portland Street tube station when I was sitting on the Metropolitan line and I was reading my old paper, The Times, and I had it on the floor of the carriage, and I was looking at it and I was reading a leader on Yemen. And so I was reading a letter on Yemen, and I was looking at the leaders column on the other side. And I found myself thinking, imagine how cool the world would be if the people who wrote the leaders really knew what they were talking about it. They were the people who had written the letters. Could you bring those people together? Could you still have a journalistic process in there, so you would test and go, well, is that true? Is that right? Is that fair? Is that prejudiced? But in the end, there was a depth of expertise in forming a point of view. And so when Jess told me about what was happening with quite so many immunocompromised people, that seemed like one of those things which shouldn't be happening, should be easy to solve, but the world is more complicated. And it felt to me as though this was an opportunity for us to try in a sort of thoughtful way to do what we set out to do, take a little more time, get to a better understanding, see whether it would take us from there and mend things. All of which is a kind of very, very long throat-clearing way of saying that this is not intended to be a panel discussion. We're not on stage. We're not doing a show. What we'd really love to do is use an hour to get the incredible expertise that you've got, as well as the considerable number of people who are joining us online, and for us to be able to understand why something obvious isn't happening. There might be good reasons for it. We might find that out, but we'd love to spend the next hour hearing from as many people as possible. Don't be polite. This is a newsroom. People aren't polite. They interrupt each other. We have one loosely enforced rule in a ThinkIn, which is no questions. We want everyone to set out their point of view, what they see. Obviously, I'm a journalist, so I can break all my own rules, so I can ask questions. But other than that, we really want to hear from all of you. I know there's going to be a touch of the AA meeting about this, so I'm going to ask everyone just to say who they are before we start, so that actually I can just kind of scribble that down and I know who I'm talking to. You've met my colleague, Phoebe. Phoebe is going to be trying to do something that we're all trying to do in life, which is live in the real world with one eye on what's happening online, and hopefully we'll get that online into the conversation too. So can I start by doing that and just going round the room, and then I'm going to sort of hand over to you, John, to ask you just to kind of, I think, kick things off, you might. Oh, there's a mic. Oh yeah, this is good. It's like a kind of children's party game. I'm James Harding, welcome.
Thanks very much. I'm Dr. Leonard Lee. I'm a medical oncologist at the University of Oxford. I led on the UK COVID cancer programme, which was funded by Blood Cancer UK, which showed the high risk to cancer patients who are immunocompromised. And I'm one of the clinical champions for this very vulnerable groups.
I'm Daisy Cooper. I'm a Member of Parliament for St Albans. I'm also Deputy Leader of the Liberal Democrats and our Health and Social Care spokesperson. And whilst I haven't talked about it before, I do have some lived experience of being immune suppressed before the pandemic. I'm not immune suppressed anymore, but I will carry that experience with me, and that's why one of the reasons why I'm campaigning so hard on this issue.
Hi, I'm Galen Coman. I'm a Senior Consultant at RPP Group. We're a public affairs agency specialising in healthcare. We support the APPG on vulnerable groups, pandemics, and Tracy's fantastic work. And John's too.
I'm Paul Howard, Chief Executive of Lupus UK. It's a charity representing people affected by lupus who are commonly treated with immunosuppressant medications, and a small number may be organ transplant recipients.
Hello, I'm Tracy Allen, and I'm political advisor to Lord Mendelsohn, and I also run the all-party group on vulnerable groups to pandemics.
Hello, my name is John Mendelsohn. I'm a member of the House of Lords. I'm a co-chair of the all-party group for vulnerable groups to the pandemic. I'm also a trustee of the Follicular Lymphoma Foundation, and I am married to someone who is immunocompromised.
Hi, I'm Benjamin Smith. I also work for RPP Group as an associate consultant and spent a vast majority of last year working with Tracy and John in the APPG.
Hi, I'm Sophie. I'm a business and marketing executive with M6 and Partners, and we're working on the campaign for the Forgotten 500k.
Hi, I'm Poppy Barnes, work very closely with Jess Burley and the team here on the Forgotten 500,000 campaign.
Hi everyone, I'm Candace. I'm working with Poppy and Jess on the Forgotten 500,000 campaign. I also live with an NHS healthcare worker who has lived through the COVID experience and really, worked on immunocompromised wards with the patients. So kind of have a bit of a lived experience that way.
Hi, I'm Hannah Harris, another of the M6 band. I'm a strategist and I'm really interested in that kind of meeting point where comms strategy can push forward activism.
Hi, I'm Neve Buckingham. I work for the stem cell transplant charity Anti-Nolan. So our patients are severely immunosuppressed and we're one of the charities supporting the campaign.
Hi everyone, I'm Victoria. So I'm the COVID-19 policy officer at Blood Cancer UK, which is the UK's leading blood cancer charity. We fund research and we also support patients through our services and advocacy work as well.
Hi everyone, I'm Laura Challoner. I'm the Policy, Public Affairs and Campaigns Manager at Blood Cancer UK. I think Victoria's covered us off, but I'll pass over to my other colleague, Helen.
Hi everyone, I'm Helen Roundtree. I'm Director of Research Services and Engagement at Blood Cancer UK. And we've led a programme of research on behalf of people who've been immunocompromised, which has been really important in laying the ground for why it's so important to protect the group that we're talking about today.
Hi, I'm Rosie McTaggart. I also work at M6 and Partners, so really interested in hearing more about the Forgotten 500 campaign.
And I've met some of you, but I'm Phoebe. I'm a reporter on our SenseMaker team, which we'll use to our newsletter, which we'll use to kind of cover what's happening right now and keep up to date with it. And I largely report on health, or what we call the 100-year life. So I'll be here in chat. And there's last count, I think over 100 people online. And kind of people are introducing themselves in the chat, so please keep doing that. And yeah.
And what we'll just so everyone knows what we're going to do, we're going to try and understand better what's going on. The reason for the bright lights, and people who are watching online, the reason for the bright lights is that we may end up clipping some of this so that people have got a sense of what that conversation is. So I want people to be as relaxed and as kind of honest and authentic as possible. It's difficult when you've got cameras and lights, but that's what it is. And Phoebe is going to sort of interrupt me and us regularly, I hope, to make sure that people who are online who contribute in the chat are brought into the conversation on the screens. John, do you want to start off? Because it seems to me, as a kind of simpleton, that there are few easy wins in life. And when someone comes along and says, there's a medical treatment for people who've, in hundreds of thousands, we'll come back to the number, it's been approved in this country already in some contexts, and in many others, this would seem like an obvious thing to happen. What's your read on why it hasn't happened?
I mean, I think you framed it very, very well. The first thing, of course, is that this is an easy win. This is a very straightforward argument, and bluntly has been for over a year. It's a straightforward argument. The issue that we have is why hasn't it happened? And I don't want to sort of do away from the compelling case now, because I think we have to make that case very strongly. But I've been living with this issue since bluntly January 2020, when this first became an issue for myself and my wife. And I've worked with the teams on this throughout that period. There is not one moment during the course of this pandemic where the UK government has got it right and has ever prioritised in any meaningful way dealing with the most vulnerable people. It's all been words. It has provably been wrong, and it has shown many failures. People failures, policy failures, framework failures. The JCVI, which has a statutory authority, suddenly became the way in which you assess what was good for the clinically extremely vulnerable, and actually the vaccines weren't going to be the solution. But it was a statutory issue which forced politicians to think in the wrong direction, not about people, but about process. In quite the same way we didn't think about the impact on people when you get them into hospital to treat them. We talked about managing the numbers going in and the flow. There's not one moment. So there is considerable anger from the community of people who have had to lead their lives with peril throughout. But at a time when we're learning to live with COVID and it's changing, the thing which just sticks in my throat and just feels just utterly wrong is that when there is a solution that can deal with the fact that still 500,000 people can lead relatively normal, careful, but relatively normal lives, can be protected, where we can empower clinicians, health workers, and others to be able to look after them properly, we have chosen consciously not to do it. And this is a decision which has been going on for over a year, and is absolutely absurd. And it relates to a drug, and I'll just make this final point, James. It relates to a drug which, if you look at the timeline of COVID, it has been provably, and it is in so many countries with so much evidence, it has provably been shown to be more effective across more strains of COVID than any other drug that's been on the market at any stage. And yet we in the UK are still the ones to say we're sceptical of it when it is standard practice and used most, widely in many other health systems. This is a real problem and a real demonstration of major failure. And that's why it's such an important campaign, not just for the people who are going to benefit from, have their lives back, have their families' lives back, but it shows a major flaw in what we've done and what we've failed to do in the UK and what we've got to do in the future.
And John, I want to come back to that, and I think I'll ask Daisy this question too. So you point to process. Is your understanding of the reason it's not happening for reasons of process, passing the decision to other people, or fundamentally for reasons of money?
Well, I think it's priority. I think it's priority. The people who have been given the least priority in this are the most extremely vulnerable. It's a policy and a political decision. And I think there have been people involved in that process who I have a very difficult time to accept, who are involved in the research, the clinical science community, the government scientists, a whole range of committees, some of whom I know, and I wish one day they will be public, about their misgivings about what the government has done. But this has been driven by political considerations, timid, incorrect, and timid considerations which do not address what people need and what's needed for COVID, but for other things, one of which does include the notion of budget, but only because if the government spent the money wrong, it's not prepared to spend money on those who most need it. It's the incorrect exercise of a monetary decision. We made a mistake in the first place, but we're going to now say a patient community will suffer because we made a mistake.
So sorry, what's the original mistake?
They overspent money on drugs budget on drugs which aren't effective.
Oh, I see.
That will be one argument which the system will say, ministers, don't think about approving this, you're overspent on the drugs budget. It's why, in my view, we're in a nice process. They're trying to deal with this without any sense. 500,000 people are still shielding, and even beyond that, a lot of people who could get the treatment face uncertain risk if they were to get COVID. All of those people could be liberated. We could release costs on hospitals, we could release economic productivity, all of those things. It is an absolutely classic, terrible Whitehall process of decision-making and very timid political decision-making.
Okay, I'm going to come back to some of those things because I feel like this is not my calling in life, but I'm going to have to ventriloquize Steve Barclay at some point. So, because to try and sort of go through what his argument is or what the DOH's argument was and see whether it stands up. But Daisy, can I just ask you, do you think it's the same thing, that essentially political decision-making has trumped clinical research?
Yes, I do. And I think maybe I thought I'd take a step back. I'm sure others will cover the science of it all, but I thought I'd just give a bit of comparison with other campaigns and how issues tend to come to the fore in the political world. I think for many individuals, whatever the injustice is, a lot of individuals, when they suffer an injustice, whatever it is, they feel it's really obvious. And they wonder why politicians can't see it. And they think it's so obvious, why can't something change immediately, particularly when I'm giving you the answer? And I guess what I would say is, as an MP, you often see thousands of people who are all shouting their obvious injustice at you, and you have to kind of see the wood for the trees and work out which ones are more important and which ones can be solved easily. And I do think there is a tendency in Westminster, in the political world, when there are so many issues being thrown at you, I think it's too easy for politicians to say, well, actually, I'm going to do the easy wins, deal with the issues that matter to the most number of people, because that will get me the most number of votes. So if you're focusing on the big issues where you can affect the most people most of the time, you're going to be talking about big issues like GPs and dentists and hospitals and all these kind of things. And actually, some of these issues that only affect a relatively small number of people often go by the wayside. Now, there are campaigns that I've been involved with, like the cladding campaign and the campaign on access to care homes, which were similar kind of campaigns where it was a relatively small number of people who were involved, but the scale and deepness of the injustice was so severe that it managed to penetrate that Westminster bubble and managed to get onto people's agendas. Now, the reason I draw the comparison with the care home example is because, we now had this problem in 2020 where protections have been put around care homes to protect the people in the care homes, but those protections were so severe, it ended up feeling for the people in the care homes like they were in a prison. And many people started to die because of neglect. And I think there is an incredibly stark comparison with the situation that we're in right now. Effectively, people who are shielding because they're immune compromised or they're immune suppressed have been left with no option but to shield. Now, this morning, we had a briefing with Robert Jenrick, the Minister. It's not Steve Barclay anymore, I'm afraid, James. You're slow news, you have to speed up. A wee tad to keep you on top of the reshuffles. He did write the letter, you're right, yeah. It's quite a lot of churn these days in politics. But we had the briefing this morning, and there was lots of talk about, lots of talk about there could be some antibody testing, and we could start it on a few people, and we couldn't, maybe we'll roll it out next year. And I just said, there was a point at which we were delivering 1 million jabs a day in this country. We were delivering 1 million jabs a day. Why can't we just do antibody testing for 500,000 people in the next 7 days? Right? This should be possible. And so the question comes down to the same question that was raised a minute ago, which is, why isn't it happening? And I think there's probably 2 or 3 different reasons. One potentially is a cost question. I think that's definitely one of the factors. It always is for government. The second is, I think this has really fallen down the list of priorities for the government. At one point in time, we had a minister for vaccines, right? And that's all they did. They were just in charge of vaccines. We don't have that anymore. The person in charge of vaccines is also in charge of public health and lists about 10 different things. So it's really fallen down the list and doesn't have the same attention that it did have. And the third, which I really worry about, is, and it has only been suggested to me, so this is just a suggestion that I'll put out there, there does seem to be this focus on making sure that somehow we're on top of the science somehow, and that we've got better science than other countries. And in the process of trying to make sure that we've got the best science possible, we're actually sacrificing people's lives. I mean, that's really what's going on. And the idea that you can treat people as guinea pigs in this process, I think fundamentally is immorally wrong. People are trying to live their lives and they can't, and the government have it in their gift to fix it.
So Dave, Dr. Lee, I'm going to come to you in a second if I might, because you're nodding quite vigorously and all that. But Daisy, can I just understand something? So the thing that is frustrating in the Barclay letter and in the nice statements and in all of the stuff, no one actually talks about the money. So can we just talk about the money for a second? But I emailed Jess and I said, because as people here will know, Evusheld has now been authorised for use outside the NHS. So if you can pay for it, you can get it, right? And I asked how much it cost. £1,600. apparently AstraZeneca is saying they could do it for £1,000. So that works for my level of maths, which means you're talking about basically 2 shots, as I understand it, £1,000 each, 500,000 people gets you to £1 billion, right? That's a £1 billion bill. You can understand why, if you're a government minister in the middle of an economic crisis with a massive funding problem, that if your medical advisors are saying to you, we are not sure about the efficacy of this drug, if we are not sure about the efficacy of this drug, we cannot go out and spend £1 billion. What do you say to people who say that?
Well, there are 2 things I would say to that. The first is that the costings that AstraZeneca have published are for individual purchasing. Government and the NHS has enormous purchasing power, and one of the reasons why the NHS does so well internationally in terms of its cost effectiveness is because it can do this bulk purchasing. So it simply wouldn't cost that much if the government wanted to negotiate a good deal. The second way of looking at this is, what is the cost of not providing this? And I outlined some of this in a debate we had in Parliament last week. There's an economic cost that's very obvious, which is that some people have had to give up their jobs, other people have had to give up their caring responsibilities, other people have given up running community-led organisations where there's no other community group that can step in and run something. So they're actually providing essential services in many kind of remote locations around the UK as well. But there's also the emotional impact. You know, if you are a grandchild and you can't hug your grandma or granddad and you haven't been able to hug them for 3 years, that's going to leave you with some emotional scarring. If you are a child coming home from school and you think, and then you know that 3 of your classmates have got COVID, or more like 30 of your classmates have got COVID, and you know that your mum or dad might die if they get COVID, can you imagine the trauma for that child? I mean, the cost of not paying for this, I think, is just terrible.
Okay, I'm going to ask Dr. Lee. I don't know if I can call you Leonard, but yeah, Dr. Lee. The arguments, if I read them right, and I'd love to get sort of some medical kind of guidance on this, the arguments that the government has put out, as I read it, is essentially, one, we just don't have the evidence yet. Take John's point that you may think that's political decision-making trumping where the research is, but they're saying we don't have the evidence. 2, you say there are 500,000 people. It's not at all clear it's as many as 500,000 people. And 3, it is clear that Evusheld may have worked for Delta, but it is not clear that it's worked for Omicron. So would you just address that? Because that seems to be the government's argument so far.
So the government's argument is that they don't know how long this drug works for. Right. But what I would say is that 32 other countries have looked at the data and the evidence. France, Israel, America rolling this out. Even Malaysia's rolling it out. Lots of people have reviewed the evidence and feel confident to make a decision here. And it seems to be working in Omicron across the rest of the world, which is fantastic. And so this efficacy argument it's really difficult, actually, because you ask the clinical experts, they say, well, look, the evidence is out there. It looks like it's working in these countries. What more do you want? What is the evidence of proof that you require? Are we looking for a perfect decision? Do we want a perfect answer here, or can you give some protection in winter as it surges? And actually, most people want to make the pragmatic decision here to protect the vulnerable this Christmas. I want to go...
So can I just ask you a question? On the efficacy point, is it possible... I mean, what we look like, we're all now amateur, virologists. Is it the case that its efficacy obviously fades after a period of time, and that the government's worry might also be that the efficacy is shorter and it's going to be more than 2 shots? You're going to need to keep doing this regularly for, quarterly, every 6 months, for years to come.
So no one really knows what the government's argument is because they've not really enunciated it, and that's the honest truth, actually. But I think the variants are getting cleverer, so just like vaccines don't work perfectly anymore, perhaps this antibody may not also work perfectly. There's no evidence to prove that at the moment, and therefore that does need to be monitored, and they can monitor it. But are we looking for the perfect solution here? Would people out there accept 90% protection? I mean, this is a glass half full or a glass half empty or no glass at all. We've gone with no glass at all for immunocompromised patients.
I just want to say something, which is that we're talking about, I said to Daisy, we're talking about 2 shots, it's going to cost £1 billion. What I'm trying to work out is, realistically, when you do roll this out, do you as a government have to be prepared that you're going to have to do the first 2 shots and then keep on topping it up on a regular basis from here on out?
I think the problem here is that we have no policy to implement it. But I mean, the delivery in itself is going to, I mean, there's people out there willing to make the plan for delivery, but we can't get over the first step, can we? Which is there is no protection for the immunocompromised with this new form of treatment. Yeah. I think one of the things I want to reflect on is what Daisy's comment said here. You can't see the problem. The problem is that people who are immunocompromised are shielding. They can't see family. They can't hug loved ones. And if you can't see the problem, how can you fix it? How do you advocate for people who've got cancer, blood cancer, transplants, autoimmune disease, primary deficiencies? Because they're out there, they're suffering. There's huge mental health toil whilst this is delayed. And actually, I think it's fantastic that we're trying to make the case for them because they can't be in this room with us. They're all virtual. Yeah. And that's the most difficult thing, actually, that they're on notice.
So can we just do the other 2 points? And I'm going to come, Paul, to you in a minute, and back to you, John, in 1 sec. So can I just, 2 other points was, it's not 500,000 people. That's what the DOH seems to be saying. Is that true? Is it? What number should we be talking about?
500,000. That's a large number. Well, it's not a large number. It's a minority, a very, very vulnerable minority which are at risk. I think within that group, you might push me, and I'll say actually within that group, you can find extremely high risk there. But the cohort of people who've got whose immune system doesn't work very well, they can't defend against this virus, they can't respond fully to this virus, is about 500,000. So I would confirm that number. It is.
And then the Delta Omicron point that they make, because I hadn't realised that Evusheld had been authorised for use against Delta, so it has been used in this country.
It's authorised for use against. Full stop. The MHRA approved this in March. It can be used against any variant.
Okay. So essentially, you don't buy the distinction between Omicron and Delta.
I think Omicron's different from Delta. It is less severe, but if you don't have an immune system and you can't defend against a virus, what does less severe look like? Maybe you might spend less time in hospital. Maybe you might spend less time in ITU. And maybe it might not be quite as mild, but the severity is still there. So I think it's a less severe virus. It's not that many people in a healthy population in the hospital. But what about the immunocompromised? And what about their case?
So I'm going to do there's a slight touch of pass the parcel here. Paul, do you want to Paul and then John, and then I'll come round to you. Oh, there's a mic there, and I'll come to you, Helen.
Mark Oakley wants to come in as well. He's online.
Okay, thanks, Phoebe. So Paul, you were going to say?
Yeah, so for me, one of the things that stood out most from Steve Barclay's letter was the threshold of evidence seems to be different for Evusheld than it has been for the post-exposure COVID-19 treatments and the vaccines, and that they were claiming there was a lack of evidence, sufficient evidence that it would prevent transmission or prevent contraction of COVID-19. Well, if the evidence threshold for the COVID-19 vaccines was that they would prevent someone from contracting the virus, then they would never have been approved. What we should be looking at instead is whether there is sufficient evidence that Evusheld prevents people from developing severe COVID-19 or dying as a result of the virus. And my understanding is that there is strong evidence that that is the case. So why is there a different threshold for evidence for Evusheld than there has been for the other treatments for this particular group of patients?
Thank you, Paul. George.
My very small technical points are actually the government, when they were trying to inflate the cost internally in debate, called it 400 million. It will probably be less to deliver it. The deal that you could do is considerably different from the numbers that you're being told. Look, I think that this comes down to a very simple issue, which is if we're going to live with COVID, vaccines are going to be part of this, as are treatments. And those are two different things. So we have vaccines, we have treatments. For those people who don't get an immune response from a vaccine or get a limited one, there is an alternative now called pre-exposure prophylaxis. This is what Evusheld is. That doesn't mean you might not need treatments or other things, but the thing that you can do to have that level of protection, which will bring people out to a way that they can live a life which is different, is by bringing that in. That's the flaw that we have at the moment. And let me tell you why I think this is crazy in the UK. My wife's a shielder. We shielded as a family. We never went out. I never went out anywhere. In 2021, my wife was appointed to a post to go and live in New York, and she now lives for part of the year now in New York. She went over to New York to shield in New York, but she's been treated with pre-exposure prophylaxis. She's had Evusheld. She leads a careful but utterly normal life. She flies. She goes out. She's had COVID and has been protected and that's Omicron as well. She's had all of that and leads a normal life. She has antibody tests. All this is provably and clinically clear in every other jurisdiction with thousands upon thousands upon thousands of cases. This is not a theoretical exercise. So the idea that we're suddenly using science, which is on paper clear, in practice utterly clear, as a mask for this, is utterly crazy. That's what the real problem is. If you go to any other country which has got this, they just cannot conceive of why we don't see what is absolutely plain, in clear sight and obvious. That's the problem.
Helen.
So it's definitely true. I mean, Evusheld is a combination of monoclonal antibodies, and it is true to say that monoclonal antibodies are more susceptible to new variants and to the virus as it inevitably changes over time. However, we already have monoclonal antibodies that are used in treating people with COVID, and the government has an ongoing programme of being able to monitor new variants and understand the extent to which those are susceptible, to the extent to which the monoclonal antibodies are susceptible to those new variants. So there's already a programme of monitoring in place. So this argument that as a solution, it's not going to be resilient to inevitably how the virus changes, is completely at odds with already an element in the government's strategy. The other point I just wanted to make, which is around cost, is that some of the patients that we're talking about have received incredibly expensive treatments. So, Niamh, you'll know this as much as we do, but a patient who receives a treatment like CAR-T, that's probably half CAR-T, which is an incredible treatment for patients predominantly in blood cancers, but now also in other conditions as well. That treatment is about £500,000 to treat an individual patient. So you've already invested a lot of NHS money in the care of that patient, and then you're putting them out there without any safety belt on. So we've got a safety belt there that can protect patients that we've spent a long time and a huge amount of effort keeping alive, and we're not using it. And that feels like when we have these discussions with clinicians, what they say to us is they want it. They want to be able to have a solution there, to be able to prescribe something, to have that tool in their toolbox. And we've essentially politically made a decision not to equip clinicians to be able to make that clinical decision.
Thank you. You mentioned Mark Oakley.
Yeah, Mark Oakley and Jess Burley's got her hand up as well.
Oh, brilliant. OK. Can we hear from Mark and then Jess?
Hiya.
Hi, Mark.
Hi. So I'm Mark Oakley. I'm one of the lead campaigners for Evusheld for the UK. And I've also been living this dystopian nightmare, I suppose you could call it. I just want to pick up on one of your points initially, James. The costs that you mentioned there, I actually spoke to AstraZeneca yesterday, and it's actually £1,000 for both the injections. So that's the total price.
And that's why, and Mark, just so I'm clear then, because Daisy suggested it would be much lower, and John used a number of around 400 million.
Yeah, that's for private though.
Right. So you're expecting, we're talking about a few hundreds of millions is what we're talking about then.
Yeah, and also if you look at what America's paid, depending on where the government decides to muck up the parity rate with the US dollar, you're looking at they've paid somewhere between £400 to £500 a dose on the kind of bulk that they're buying. So it would be, we would imagine, significantly lower. But you can put all the numbers and play around with them as much as you like. But what it comes down to, as Daisy said, is the people's lives and the people, how they are affected. And because you're playing with numbers, costs, thousands of people involved, etc., it's the individual lives that get lost in this.
Yes.
I'm on my 951st day of shielding now. I live with my wife and my two youngest daughters. My eldest daughter, I haven't held or cuddled since this all began. I haven't held or cuddled my 91-year-old mother since all this began. And you can talk about the economic factors. At the beginning of this, I had to shut down my successful landscaping company, close the company that was profitable, earning a tax income for the government, and I had to lay off 4 people. So they were then unemployed. If you take this week as a typical week for us, on Monday morning, my daughter woke up with COVID-like symptoms, which meant I had to isolate from the family, living in a summer house again. My daughter's face was just absolutely ashen because she thought she'd brought it into the house again. Monday afternoon, my father-in-law was taken into hospital. My wife then had to go to him because he's elderly. I was left then trying to cope with a household with two daughters that I'm trying to isolate away from, and they're suffering that, you know, the trauma that I possibly could get it, and they don't want to come near me. I've got to keep a house running, and their grandfather is in hospital, seriously ill. Yesterday, we find out he's been moved onto a ward where there are other people that are COVID positive. So my wife is then put in a position of, do I go and see my father who's possibly at the end of his life, or do I not go and see him to protect my husband? I'm put in a position, do I again isolate from my family? My daughter is at sixth form college. Her results are so good, she's been told by the college to apply for Oxford and Cambridge. As a result of the mental pressure that we've been through as a family, she is now having to take drugs to deal with her anxiety. And the prospect of her going to sixth form college, to university of any sort, is at the moment off the horizon. And that is how this is affecting people's lives, not just the people that are immunocompromised, but the extended families as well. And it gets lost in all the numbers and all the costs and all the arguments for the science from this. I would take this if it gave me 50% or 40% protection. It would be better than what I've got now.
And can I ask you, and Mark, can I ask you, so your understanding of people in similar circumstances to you in the US or Israel or Canada or France or any of the other 32 countries that have authorised Evusheld is that when you're in touch with people in similar circumstances to you, if you took Evusheld, what would be the change in the relationship between you and your daughters, you and your mother?
I could go and hold them. I could hug them. I could walk out the door and do all those spontaneous things you do, like walk out the door as a family and go to a restaurant. I'm not going to go into a packed restaurant, but I can still go down to the local cafe and sit there. I can walk into a shop. I don't have to walk out the door and plan through everything. We don't have to look at everything our daughters do. Is it safe? What are the risks? My daughter came home from school yesterday because one of her friends phoned her up and said, my mum's tested for COVID and I've got a very faint line. She's again horrified. That's the difference it makes. It's about people being able to live a life without looking over their shoulder or walking out the door and having to plan, where do I go when I walk along the road? How do I avoid these people coming towards me? And that is how they're having to live their life at the moment. And it's no way to live a life.
And Mark, the point that John made at the beginning, which is this has been going on for a year, how do you understand, or how have you come to understand why this has taken so long? Why nothing has happened for so long?
I mean, we've been involved in this for quite a while, and we've obviously worked with John and a lot of the other good people that are, you know, associated with this. And a lot of it has come down to the, you know, the consequences of, you can trace it back to the consequences of people in government not being honest, telling lies, you know, the Partygate, etc. And it does have knock-on effects. When you get ministers resigning and a government virtually falls, and then you get a void over the summer recess for 8 weeks where no one is willing to make a decision, no one is willing to move anything forward, there's nobody left in government advising. Civil servants are therefore, who should be giving advice and then letting a minister make a decision, are just too scared to do anything. This is what we get left with. And we're seeing it again now as we're watching the shambles in front of us.
Well, I think if you're on a screen, you'll be watching a shambles, because I understand the Prime Minister's resigned and that there's a 1-week leadership contest. Matt just messaged me to let me know. Jess Burley, are you there?
Yes, I am. Hi, everybody. And firstly, James, thank you very much for convening this group. Thank you, everybody that has already spoken as well. I mean, firstly to say, I do happen to run the agency, the AM Partnership, and M6 and Partners team that has worked on the Forgotten 500,000 campaign. And when I contacted James, I also shared with him that I am married to an immunocompromised person. So I have a lot of skin in the game on this from a personal perspective. And one of the great pleasures really of having done this has been able to meet some incredible people, not least Mark, Nicola and Martin, who I know are all here, leading the Get Evusheld UK campaign. It's a patient group. It's really well organised. We're not talking about people that are being, emotional or militant or rallying. We're talking about rational, educated, considered argument from a patient group. And then put against that, working with Leonard and the oversight committee that he's put together, you understand that there are lots of medical evidence available as to why Evusheld does work. I think actually the fact that AZ has at least made it available privately, it's not enough. This campaign was not for a small group, it was for the 500,000, so it still needs to be for the 500,000. But the fact that AZ has made it available tells us it's not dangerous, it does work. There are clinicians that want to prescribe it, and there are patients that want to take it. So it's unfathomable, really, as to why the government wouldn't buy it and provide it. And if it is a cost argument, then it needs to be a balanced argument, and it needs to be balanced against the cost of the risk of any one of these individuals this winter being in hospital. And if they are in hospital, then it will cost, I think the numbers are, if they are in hospital but not on a ventilator, it's £2,043 on average per day. Well, you only need 1 day in hospital to justify giving them Evusheld. If, however, they are in ICU and on a ventilator, it's 3,145. The average length of time that people with these conditions in ICU or in hospital is actually between 16 and 29 days. So we're not talking about 1,000 or 2,000. We're talking somewhere between, I don't know what it is, 32 to £60,000 per person risk. So there isn't an economic argument. Or is it actually just that, and unfortunately it probably is, if the Prime Minister has just resigned, that our government just is not in a position to make any sensible decisions about anything. And this is a truly life-saving decision, and therefore must be made and must be put to the top of the list.
Jess, can we? So I want to make sure that in the sort of last 20 minutes we sort of focus on how do you run a campaign that then makes it that then has a different outcome. Jess, I mean, I've seen some of the kind of artwork that you and the M6 gang have done and trying to raise attention. It's odd it doesn't cut through or hasn't cut through yet. Is there a read from your point of view on why that is, and how you get this message out? Is it just that it's been drowned out by the chaos?
Yeah, I mean, I don't know that it hasn't cut through, by the way, because is it by chance that AZ had decided at least to make it available outside the NHS this week? Is that a coincidence, or actually did somebody hear us? I think the campaign...
Sorry, I didn't mean cut through, Jess, I didn't mean cut through in public consciousness, because I think actually people have really noticed. What I meant was that Daisy said she had a meeting with Robert Jenrick, and you'd have thought he would have gone, OK, well, this is mad.
Yeah. I mean, I don't know really, because in my career, I've never had such an enormous group of clients to support in a campaign. So, 16 charities gratefully galvanized together by Blood Cancer UK, but nonetheless still 16 charities inputting, the patient group, the medical oversight team, and John Mendelsohn and his team. I mean, that's a lot of clients. So I think we need to really make a stand. It's difficult for this group to make a stand publicly, obviously, because they can't get out. And so I think our next moment will be next Wednesday, where we run a vigil on Parliament Green. I'm not quite sure who we're going to be handing the letter into, though, at number 10. And that's a problem in itself, because it's such a rotating group of managers in Parliament that we find ourselves in a pretty tricky position, James, to be honest.
Jess, thank you. I just wanted to ask Niamh, and then I'll come to you, Daisy, in 1 second, just because, you know, Anthony Nolan, as a, you know, heaven knows, has an amazing record in kind of getting itself in the public consciousness, impacting decision-making. When you look at this, what do you think can be done? What should be done?
I think it's really hard, and I think also I would like to say that the argument about that we've got this safety net for immunocompromised in terms of the treatments that they can then receive if they do catch COVID, we know that that safety net is very, very patchy, that a lot of the effectiveness of those drugs are now under question, and that the CMDU system, which is sort of the medicine system in England for receiving those treatments, is probably not going to be able to withstand the surge that we're expecting in winter. So I think, firstly, I would like to just make that point that this so-called safety net doesn't really exist. And then secondly, I would say in terms of getting the cut through and how do we make this change, I think it's really, really hard, and we can get as many clinicians on side and people affected, but ultimately it's going to be that political decision, and the decision in itself to refer to NICE, I think, was very reflective of where the government are. So unless we have quite a new change in direction, which is obviously not impossible in light of recent events, I just think that unfortunately, unless we see really, really truly traumatic scenes this winter, that is just not going to move, because the government want to, unfortunately, have this idea that we've moved past COVID, and it's just not politically convenient for them to even acknowledge that it's still an issue that we need to be talking about. They don't want to be talking about it.
As an MP, there is nothing more powerful than meeting a constituent face-to-face and hearing their story. And when I say face-to-face, I include Zoom.
Yeah. Well,
because, yeah, quite. During the pandemic, all of my surgeries were on Zoom, and people were joining the Zoom calls from all sorts of peculiar places. But I would encourage, if they haven't done it already, I would encourage anybody who is affected, including friends and family, to contact their MP and to demand a surgery. Now, during the cladding crisis, the fire safety crisis, one of the turning points was when that cladding campaign actually started emailing their personal stories to their MPs, and they started recording videos and sending them not just to MPs but also to members of the House of Lords, because it was really critical for us in terms of legislation to get members of the House of Lords to realise how big an issue this actually was. And so they were sending out these video links saying, here's a compilation of different videos to tell you about my life and how I am affected. This is what my life is like. And we've all just heard, all of us in this room are familiar with the arguments, we're familiar with people who were affected, and yet sitting here, I still feel affected again by hearing Mark's story. You know, and if we're affected, just imagine how that would be for an MP who hasn't actually listened to this story yet, who hasn't heard that kind of the pains of anguish, quite frankly, that we were hearing. So I think one of the ways in which you get their attention is through having those meetings.
And can you fill us in? So what happened with Jenrick?
This morning?
Yeah.
Well, he had about 4 advisors with him, and I won't name them because it's ministers who are accountable. So he had 4 officials with him who are medical scientific advisors to him and the Department of Health. He invited them to give an introduction. They repeated everything that we know already, but fair enough, there were some MPs on the call who maybe didn't know it all. And then we were invited to ask questions. The questions that I put to him, I think there were 4 or 5 questions that I put this morning. One was, I said, what is the timeline for looking at the research you committed to look at last week? This is the Francis Crick Institute research that was covered in The Lancet, research that the government itself had actually commissioned and then conveniently left out of the advice note it looked at last week. So what was the timeline for looking at that? We weren't given a timeline this morning, but we were told that it was, quote, actively under review. So, you can work out for yourself how active that is. We also said, what is the timeline for NICE doing its accelerated review? Because the minister had committed last week in a debate in Parliament that he had already asked NICE, and I was under the impression that we were going to get a date today in terms of how quickly that could be done. He told us that he had spoken to somebody at NICE again last night, but he still didn't have a date. So I was very frustrated.
Because when I was confused about that, the date seems to be either April 2023 or the summer of 2023.
So when I had a private meeting with the Minister and his officials a few weeks ago before the debate, they told me that it could be April with a fair wind. So what they mean is it's not for the government to dictate to NICE how quickly they can do a review. So NICE will have to start their review, and NICE probably said, well, I guess we might be able to get it done by April, but it's more likely the summer. But what the Minister had committed to doing was having a conversation with NICE to say, can you accelerate this process, and can you come back and tell us how quickly you can do this process? And I had hoped that we would have had that date today, so they could have said, you know what, the fastest we could do it is 4 weeks, 5 weeks, 6 weeks, 8 weeks. So at least people could have seen there was an end in sight and when we might get the next decision. We didn't even get that. There were lots of other questions from MPs, and there were about 30 MPs that came to this call today from all different political parties. I mean, it's a huge turnout for a regular MP briefing. Exactly. There's a lot of MPs there, and we were all collectively from different parties speaking with one voice. Every single MP on the call was urging the government to act faster. They were urging the government to come forward with dates for when they were going to complete these 2 reviews as well. Many made the point that antibody testing simply isn't available. I made the point.
Did you have a list of those MPs, Daisy?
It was a private briefing, but I'm sure that MPs would be able to tell their constituents whether they were there or not. I certainly kept a list of who was on the call because I might want to encourage them to do some other things. But it wasn't a public meeting, so it wasn't a public list. And there may well have been some staff members from MPs' offices on the call who weren't MPs, but they're representing other MPs, so I wouldn't quite know who those people were. But people spoke, with huge passion. And one of the frustrations for me was that the response from one of the advisors was, well, we think, it was this point you made, we think it's a smaller number of people that actually need Evusheld. I don't know what their basis is for saying that, but they're claiming there's a smaller number. And I have heard estimates floated around that it's sort of 20 to 50,000 people who are really, really, really vulnerable. And I think it's fair to accept there probably are degrees of vulnerability. But how do you determine that? At the moment, they're saying, I said, well, why don't you just do this antibody testing? And they said, well, the fact is, if we did do antibody testing, everyone agrees that antibody testing isn't the only factor. Well, you're stuck in this kind of vicious cycle. If you don't know which people are really vulnerable in the 500,000, and you're not going to do the antibody testing because it's not the only factor, then you're never going to get around to treating anybody. So it is a vicious circle, and they're arguing themselves constantly out of providing this particular drug.
Phoebe, there are people online who want to join, because I'm going to want to go back to John for a second. John, will you just take the mic? Yeah, go ahead.
The only thing I really wanted to say was, we can look at it through the last argument that was presented, but we've been arguing about Evusheld since prior to the MRHA, and actually we've been arguing with ministers about it, and I've heard literally every excuse under the sun. The NHS can't provide it, different timetables. We've been through different ministers and many different people from the House of Lords. Andrew Lansley actually had a long dialogue. And in fact, we had a lot of discussions with AstraZeneca about how they could deal with it. We're getting the last embers of the most pathetic arguments I've ever heard in my life, all of which are utterly and totally provably wrong. And the thing that sticks in my throat, and I've got colleagues here from Blood Cancer UK, far more charitable to the government than I am, but we have listened to ministers and their experts over the last 2.5 years, opining on what happens with the immunocompromised, even with their medical theories, when we've had experts in the field from America, from other places, telling us what is the most likely cause, and then it being proved in confirmatory research, and the government's advisors still argue the exact opposite. That's the problem that we're in. We've got a real problem with the structure of advice, with the structure of how it works, but the most significant problem, and where this latest push with the MPs and with this campaign will make a difference, we have got to ask ministers to do their job, to scrutinise the advice that comes through, to focus on a policy outcome. And the policy outcome has to be that this country does not accept that people like Mark and all the others should lead a life like this. When you get down to saying 50,000, there are probably 50,000 people whose lives won't be protected by Evusheld. You can deal with that if you do antibody testing. But there are hundreds of thousands of people who shouldn't be in that position, and if you make a policy decision to protect the vulnerable, you can deal with this. I can even get the cost down to the smallest possible number, and AstraZeneca will even be more flexible. This is about ministers doing their job, and I have to say that I think that some have done a better job than others to push back against the system, and I just happen to think that the system had an easy chance with a Secretary of State who came in and got him to write what is provably one of the most absurd letters ever to come from a Secretary of State.
You mean the Barclay letter?
Yes, one of the most absurd letters. They got him to write that because he was very unfamiliar with the programme. This is provably different. If a minister says our priority is the extremely vulnerable, then it just makes sense. The hospital costs, the economic costs, it just makes sense.
And sorry, John, I don't understand, but part of this is trying to understand how government works. You can't go directly to Jeremy Hunt and just say, look, you used to do this, you know how a health service works, you're now in charge of the coffers, can we make this work? Can you approach the Treasury, or they'll just send you back to DOH?
No, this has to be one which is in the context of how you deal with COVID and how you have those policies and how you distribute it. So it is a health department issue. It is certainly true that there are other ministers who occupy other positions who cannot believe the tis we're all in. And frankly, if you read the Kate Bingham book or even the extracts, you will understand where we are in relation to the system.
Where is she on this?
No, I don't think she's got a specific... Have you spoken to her recently?
No, she has got it. So so Kate Bingham was the remarkable lead for the vaccine programme, and I think, you know, that's such a great example of how all of these issues can be overcome. But she said in her most recent interview that there was essentially a deal on the table for Evusheld last year, and she doesn't understand why we didn't move on it at that point. And from her perspective, it's just an absolute failure of the machine of government to be able to respond to something that was there that could have been...
She's a very powerful champion.
Exactly.
She's doing the rounds at the moment, and she's... Sorry, John.
If I can just push that a little bit further. We are aware there was a deal on the table, and we are aware that some of the ministers in place at the time who changed were minded to make that decision, and that it was possible. AstraZeneca were extremely flexible on both pricing and on arrangements, even to the point of saying to government, if it doesn't work, you can get your money back.
And what happened?
There are ministers who come in and just get bounced by the system and don't make the right decisions. And the letter that you refer to is one of those. This has been available for a long period of time to the UK. So ministers have to do their job.
So if I'm right, pre-Barclay it was Nadeem Zahawi was poised to do a deal?
Well, you're a journalist, that's your job to find these things out. But if you trace back who's been in position... and
but if I go to Nadeem and say, were you in a position to do a deal, I might find the answer was yes.
Well, I have to say, you're a journalist, you will look at it and you will look at all the ministers in post, and you will make your phone calls and you'll decide whether or not you've got someone who'll be attributable or unattributable, but you'll be able to find a more strong truth which reflects what Kate Bingham has now made public.
If only I had more sources, if I had more people plugged into this particular story, see what we could do.
Sorry, I'm just gonna try and do a really quick summarisation of online, because we've had so many people talking. I think there's just been a couple of points, and then I think we're going to come to Alison Railton from Kidney Research UK, because she's on the call and making some points.
And then we're going to have to wind up because we're going to keep tight to the hour.
Yeah, absolutely. So one was from Sophie Wintrich from MDS UK, who made the point about long-term rehab of hospitalised COVID patients, and then also time at home, and the fact that physio staff, I think this kind of holistic viewpoint is something that a lot of people have said, you know, the cost of my kidney surgery, etc. And also I think, you know, Martin put it best, we have spent 6 months trying to lobby the government, but there's barely been a government there to lobby. I think a very succinct way of putting that. And then also someone who's talking about other kind of immunology treatment they've had and the difference that it's made to them. But if we can come to Alison just briefly, and also note, and just to say as well, Lucy Huberman's been in the chat, who's a long-time friend of Tortoise. And please do send me an email, Lucy, and we'll come back to your points. Thank you. Yeah, is that Alison? Can we hear you okay?
Yeah. Sure, yes. Can you hear me?
Yeah, fantastic.
So, yes, I just put a comment in the chat about the Melody study, which was funded by us and other charities, part funded by us and other charities, that is looking at the response to the vaccines that immunocompromised patients have mounted, and most importantly, the outcomes. So 30,000 patients were recruited and measured over time to see their response to the vaccine and the outcomes. So that the results of that study should be available soon, and hopefully will demonstrate which types of patients would benefit most from Evusheld.
Thank you. I appreciate, we try to keep these things to time, not least because someone once said to me that a newspaper is an argument on a way to a deadline, and actually having the deadline is probably quite healthy. What we used to do when we held these kind of leader conferences at the Times or in other newspapers was always to try and come away and say, okay, well, what having heard all the things we've heard, do we think? I come away actually with kind of 4 really simple, I hope, observations. One is the point that Daisy made, which is you can get hung up on the numbers, but look at the people, was so kind of powerfully made by Mark. Then just hearing the story of actually think of the human, not the financial, and just those things that he said about his daughter and about his mother are so powerful, and obviously they're so powerful in, as M6, as you guys will know, in campaigning terms. The point that I would make, which is that journalists like me who think, oh, there must be a kind of rational argument for something as irrational as this, then reach for the numbers, and then to see them sort of taken apart in the way in which Leonard, you did, and then Jess did, that showed, A, the cost of this is not what the ticket price looks like. It's much, much less than that, but also what the knock-on costs that Mark mentioned in terms of economic impacts, but also obviously in terms of direct cost to the health service if we go into a very, difficult winter. That point about 2,000 in the ICU, 3,100 with ventilator, 16 to 29 days. Those are incredibly powerful numbers. I think the point that, Niamh, you made about how do you make sure that this gathers pace, I think that the point about getting clinicians on side, it's really interesting the power, I think, curiously for a body that claims not to campaign, but obviously has such campaigning power, clinicians within the NHS, how that works. We had Adam Kay here the other night. You know how a person like that has an impact. I'm really struck by how Kate Bingham could have an impact, and I'm really struck by the way in which social media could have an impact. I do think the fourth and final thing that's really striking is if you don't know who your individual is that you're aiming at, this makes things very difficult. But I really hope that the vigil happens next Wednesday, because I think that a new government coming in has the opportunity to say, we were wrong, let's fix this. And I think using that dynamic could be really effective. And I just hope that we'll be able to do a small bit, which is just make sure that those voices that we've heard today get heard a little more widely. We've got a really canny group of people, Phoebe's one of them, who knows how to make sure we get these voices heard to the largest number of people. And I hope that you feel as though it's been a good use of your time just to make sure that all of those different points of view get heard, even if they're tested by someone who doesn't understand the details as well as I should. So thank you very much for sparing your time to come in here. Thank you, a big thank you to Jess Burley and to the people at M6 for driving a campaign like this. And thank you to Helen and to John and to Daisy and to Mark and everyone who weighed in. So thank you very much.